for 3 at the same site. We're looking now to work across the enterprise. The budget for each one of these is 1.2 million for 4 years. So you can see how by the time you get 5 of these projects, you're working at a $6 million budget. So it's very, very generous. On top of that, we offer, once you have 3 of these funded, there is a $40K supplement that will go on top of that for you to have an annual meeting. You may want to, fly your postdocs around. I find like some of these meetings, actually everybody brings their postdocs and technicians to the meeting. So there's a lot of crosstalk happening in these meetings. So they're a little bit different than a regular scientific conference. And of course, for folks who are not eligible, we ask that you have like a 5/8 appointment at the time of the submission. And for this group, the most important thing is your letter of intent to submit, which is why we're kind of doing this in September, but it'll take August. And so it'll take time to think collaboratively. So the next deadline will be November 1, and then you can submit in the spring of March. If you know it takes you a little bit more time to gather your thoughts or to generate pilot data, then your next deadline to submit an LOI is May 1 to then submit in September. And I just have some of the peer review timelines here, and always discuss with your program manager so they can kind of give you best advice. Or if you're kind of looking for someone across the network, they can potentially hook you up. And I always tell people, you can look inside of NIH Reporter, you can find VA funded investigators perhaps working in adjacent spaces as well. And I think people are really excited about the possibility of, working together and working across the VA research enterprise. So from the reviewer perspective, I think it's most important that you name your team. That's how we call you. That's what we call you by. We just finished a team meeting out there in Indianapolis, and they've come up with their name called, they're calling themselves Bones, and it's all about bone and bone biofabrication. So you want that name to mean something, and then that's your name. And I say this team is, we call you by that name. It also helps the reviewers link everybody up together. When they're reviewing you on panel, they're going to be like, oh, we're reviewing all the projects on this team. Develop your workflow diagrams and how the teams are going to fit together, or how the data is going to be shared. We encourage you to start thinking about generating data with team members. People, reviewers will forgive you for not having a history of working together, but they definitely want to see, see how that you laying out how that synergy is going to work. If it's data sharing, if it's bioinformatics, if it's specialized equipment at your facility. And again, this helps us figure out how the teams are organized. You're giving them a high level overview and then how they'll be reviewed. So again, giving them like a full picture of, how these will work together and where you're going. And hopefully at the end, you have a product that will come out the end, or a product ready to enter into sort of the IND process. Some people don't get funded all at the same time. Some people are not, they're sort of in their, mid-cycle, and they want to get other grants funded. So just sort of think, who's going to go forward? How do you rescue people who don't get funded the next time? Are there projects you can phase in later? And how you might bridge across the research continuum, maybe with additional funding sources. And like I said, thinking that how that preclinical strategy supports your design, definitely thinking upfront the clinical translation, and definitely having embedded, and the most successful teams always have embedded clinician scientists, and obviously very, very most important, what veteran population you're hoping to treat, and of course the ability to recruit that population if you do get to trial. And the beauty of this, and I know the reviewers will give you a pass, right, when they start to see how many sites are involved, because they say, oh, this can only be done with 6 and 7 sites, either the number of patients or the amount of samples, perhaps if you're doing a big data analysis. So they do recognize the power of multi-site collaboration. These are just examples of other translational mechanisms that we have. So they're like I-21s, and then you can sort of say, okay, I'm going to do some population studies. So again, you can spin these out, or you may look at scaling up in terms of novel targets and things like that for lead product isolation and pre-IND studies. So these are things that can be spun out of the collaborative. They don't all have to go inside of the collaborative mechanism. The other one I offer is the data science. I think many of the people on the call, many of the people collecting samples in, and wound care, the wound samples, they're doing a lot of bioinformatics. And again, you may want to then recruit your bioinformatician to help you with the curating of the data, and the management of the data, and maybe the hypothesis generation. So this is just another mechanism whereby we can recruit 2 VA data scientists, and this will be sort of PhD, not MDs working clinically, but PhD scientists to help us manage the vertical integration of the data that you'll be collecting. And again, the letter of intent deadlines are the same. The guidance is on our website in terms of submitting that LOI. And again, I'm going to end here. This is kind of what we're looking for, is a sweet spot with our community of science, folks sort of working in the big development space with FDA partners in the innovation ecosystem. And of course, nothing will be possible without involvement of our clinical science and of course our clinical offices, which again, that's a lot to take in. And again, thank you for your attention. I'm going to hand it back to Alyssa. And I guess we can all take questions at the end, Alyssa. So
yes,
thank you. Thank you very much.
And if you type them up in the chat, I'll get to them at the very end. We'll go through all of them. I'm keeping an eye on that. Well, Kimberly, thank you for that very valuable information session. And Linda, thank you for the intro. So our first speaker is going to be Kath Bogie. She's a research career scientist from Lewis Stokes Cleveland VA Medical Center. She's a professor, Department of Orthopedics, Case Western Reserve University, with an international reputation in translational research, leading various interdisciplinary teams to develop patient-centered interventions to meet complex multifactorial problems of wound management. She has a whole list of contributions to science here with evidence-based medicine. Interestingly, she was elected a fellow of the American Institute for Medical and Biologic Engineering, recognized for outstanding contributions to wound biotechnology development and patient-centered pressure injury management. And so I think I'm going to stop there so that we keep on time. So please give a warm welcome to Dr. Bogie as she presents biomarkers for recurrent pressure injury risk.
Thank you, and I hope you can all hear me fine. So my presentation is one of the projects that we've been doing that was initially funded through the Craig H. Nielsen Foundation and the Department of Defense, and is currently funded by the Department of Veterans Affairs. It is somewhat different from the rest of the presentation. So one of these is not like the rest because we're looking at biomarkers for recurrent pressure injury risk. So not specifically regeneration nor wound healing. I do have other projects in those areas, but that's not what I'm going to talk about today. And I guess going back to the introduction that Linda gave, why do we care about pressure injuries? Well, this is a graphic from AHRQ, the Agency for Healthcare Research and Quality. And if you look, you'll see there are several areas of hospital-acquired conditions, and only 2 of them are actually increasing. One of those is pressure ulcers, and the other is surgical site infections, which leads to often lead to chronic wounds. So they're kind of interrelated. All the other chronic or major conditions have actually been researchers reduced their incidence of falls, adverse drug events, and other conditions, but we still aren't doing a good job with pressure ulcer or pressure injury prevention. So the project that we are currently working on is looking at biomarkers for a deeper understanding of recurrent pressure injury risk. And again, to Kimberly's point, this is an interdisciplinary team. I work with clinicians. Dr. Hensel and Dr. Richmond are at the Cleveland VA. Dr. Galea is chief of spinal cord injury at the Bronx VA. Dr. Alvarado is an interventional radiologist. Dr. Letitia Graves is a research. She's a PhD nurse trained in nursing and genetics. I also work with people at the Minneapolis VA on this project, along with a statistician and a genetic bioinformatician I can't say the word, but genetic bioinformatics. And of course, my study staff, without whom really nothing actually happens. So why are we looking at this? Well, as I mentioned, despite the best standards of care, pressure injury prevention remains challenging for many veterans with spinal cord injury. And there are bodies that think that the VA is doing a terrible job and that they should be able to do better. But the conundrum really is, why are some people suffering from a continuous cycle of recurring pressure injuries and long hospitalization, while others stay pressure injury free? So if you have spent any time looking at pressure injury risk factors, you'll know that the two main factors that are considered to be key to what is the risk is the magnitude of applied pressure and the duration of that applied pressure. But if you look at the clinical practice guidelines, if this was all there was, it would be a one-page monograph, but they're not. They're extensive documents. And when you're looking specifically at spinal cord injury, in some ways, some people would think, well, everybody is going to get a pressure injury if they have spinal cord injury, which is not the case. But there are risk factors that are included in the clinical practice guidelines, such as the level and extent of injury, their extent of mobility, nutritional status, age, and other demographic factors such as education, living status, BMI. In all, there's about 200 risk factors. But even if we knew how to address all of these, why are we still not getting a reduction in the incidence of pressure ulcers? And we believed, or we were trying to look at to see, is there something that we're missing? And what we believe is that really what we're missing is looking at what people are sitting or lying on. We think about, in the wound care field, we think about the interface surfaces, the mattresses, the cushions, how do we change those? But we don't actually look at what they're really on, which is the soft tissue between their skeleton and that support surface. And these, what you're seeing here is a CT scan of an individual with a spinal cord injury. Obviously, it's falsely colored, but what we have here is lean muscle in pink, low density muscle, which you don't really see much of, in cyan, and gluteal intramuscular fat in yellow. Now, the highlighted area is the gluteal region. And with somebody with a spinal cord injury, we would expect disuse atrophy if they have immobility in that region. And here we have a fairly atrophied gluteal muscle, but if you look at the content of that muscle volume, it's actually only 2% gluteal intramuscular adipose tissue with no recurrent pressure injuries. Here we see somebody with higher gluteal intramuscular adipose tissue. 40% of their gluteal muscle has actually been replaced by adipose tissue, and they have recurrent pressure injuries. And then we see somebody like this who has really no muscle left. This is the gluteal muscle, but if you look at it, it's really just a fat pad, and not very well vascularized. This person has recurrent pressure injuries. And I should say, none of these individuals are elderly. They all have similar levels of injury. They all have similar durations of injury. So the usual clinical factors that you would look at are not telling you what's going on in their muscle. Just as you can't look at somebody and see what their cholesterol level is, you can't look at an individual and see what's happening in their muscle. And as I said, we have been looking at these over some period of time. So we see that the gluteal intramuscular adipose tissue can change for some people. This person had 38% intramuscular adipose tissue when we first saw them. A year later, it was 54%. They hadn't dramatically changed their lifestyle. All they'd done, apart from getting a year older, there was no difference that we could tell in their clinical risk factors, apart from the fact that this intramuscular adipose tissue was increasing dramatically. But what we don't know, because as I said, we've looked at all these demographic factors, we've looked at the clinical factors, and none of them are explaining what is driving these changes. So the hypothesis that we have been investigating is that the genomic profiles are predisposing some individuals to increased rate and magnitude of deposition of intramuscular adipose tissue following spinal cord injury, and as a result, they have an increased risk of pressure injuries. And as I said, we're not just looking at the muscle composition. We do include all these factors: environmental factors, social, clinical, personal factors. Everything that is in the medical record is included in our model, but we're also looking at these genomic biomarkers. And you will see here a couple of other things that we're interested in looking at. I'm not going to talk about them today, but we're also looking at genomic markers for other secondary health complications that impact a lot of people with spinal cord injury, and a lot of our veterans experience these issues. So we have been looking to see what are the role that the genomics and genetics of an individual play in the risk of these complications. And specifically, we're looking at DNA, we're looking at RNA, we're looking at methylation changes. But we are collecting this data with minimal risk to the participants and minimal involvement. When we first started these studies, we were doing muscle biopsies. And even though our participants are individuals with spinal cord injury, that was the primary reason they didn't want to participate. They didn't want to have a muscle biopsy. So now we do gluteal CT scans to image the gluteal muscles. Previously we use contrast. We've now found that we don't need to use contrast in order to be able to look at the muscle composition within the muscle volume. And so they come in, they take a regular CT scan, lying supine with cushions placed under the legs and back to minimize soft tissue composition. So we're getting a true image of the muscle as they're lying on the CT bed. And then we also draw fasting whole blood samples. So for the participant, we are getting a ton of information, but the consent form takes longer than the actual procedure. And this is important because a lot of our veterans, particularly over the last few years, do not want to come to the medical centre multiple times and spend hours doing our studies. We want them to be in, out, and on with their lives. So this is our current study cohort. As I mentioned at the beginning, we actually have 3 sites: the Lewis Stokes Cleveland VA, the John J. Peters VA in the Bronx, and the Minneapolis VA. And that allows us to recruit a diverse cross-section of our population of veterans. We have different demographics for the veterans who attend the Cleveland VA, the Bronx VA, and the Minneapolis VA. So that gives us a good mix, and representative of the nationwide population. As of June, we had 78 veterans with traumatic spinal cord injury participating in the study. It's actually bumped up a little bit now. We're at just about 82 to 83. And you can see here the summary demographics. You know, it's a veteran population, so predominantly male. We have predominantly Caucasian, but we do have a reasonable representation of African Americans. We have good distribution in neurological involvement, IAS grade, and predominantly people without a history of pressure injuries. So what we have been doing is taking that whole blood and getting a whole ton of information out of it. We've run whole genome sequencing and looked at the genes that are likely to be significant for pressure injury risk, with a particular focus on fatty acid metabolites and inflammatory pathways. And what I'm going to present today is actually not the whole genome sequencing, but the RNA-seq work that we have done. And what you're seeing here, if you've ever looked at genetic outputs before, is a heat map. And across the top, you see the participants, and along the vertical axis are the genes. And yet you're not going to be able to read them. There's a lot there. This is the top 50, and this is a plate that we ran for 48 individuals. But what you can see is this sort of separation of colors. So blue means are genes that are downregulated. Red is genes that are upregulated. And there is a line down the middle. And that line actually does reasonably well discriminate between people who have recurrent pressure injuries and those who don't. And what we've found so far is that people with recurrent pressure injuries have upregulated activity in genes involved in pathways related to biological senescence, and downregulated activity in pathways directly involved in antimicrobial protection. We're doing a deeper dive on this, and we have recently submitted a plate with 71 participants, and data analysis sequencing and analysis is in progress on that. So we will be looking to see where that goes. But as I mentioned, by looking at these circulatory biomarkers and identifying the ones that are implicated in the pathways for pressure injury recurrence, we believe that we can maybe leverage this to develop a point of care technology and actually use the information that we are getting from a genomic sequencing, which takes weeks, if we're lucky, to get to sequence, to process the data, to run the analysis. That takes weeks. But if we can identify the genes that are the key players, we can leverage that information to actually build a blood test in the same way that people currently test for diabetes or heart disease risk. The goal we would be able to use a point of care technology so that the clinician and the patient can identify their personal risk status. So where are we at? So we're running an external validation of this study. As I said, we currently have about 83 participants in the study. We're doing repeated measures and funding through the end of next year with this multi-cohort study of 100 veterans. That's the goal, is to reach 100 veterans with spinal cord injury, including participants with and without history. And I guess linking it back to the rest of the presentations today, we are looking at epigenetic differences to examine the links with environmental influences, and have found that some of these transcriptive biomarkers can be indicative of increased risk for recurrent pressure injuries. For the individual, knowing their personalized risk will enable choices that can positively impact overall health, and for the clinician, it can help them to decide what sort of interventions, preventative interventions, they could deliver. But it could also help with the delivery of personalized approaches to wound healing. So regenerative medicine that actually takes into account what are you looking at in terms of tissue quality, propensity for recurrent breakdown, etc., maybe can intersect with these advanced approaches to wound healing. And I believe that's it. So thank you.
Well, thank you for your lecture and your contributions. I'm looking forward to your findings, Dr. Bogie. Our next speaker is Dr. Iseroff. She received her undergraduate degree in biology from the City University of New York, Brooklyn College, followed by a doctorate in medicine at the Albert Einstein College of Medicine. She's both a dermatology resident and a postdoctoral fellow at the New York University Medical Center. And then soon after, she became an assistant professor for dermatology and cell biology at the same institution before being named assistant professor at the University of California, Davis Department of Dermatology, where she is now a distinguished full professor. She was named Chief of Dermatology Service for the Northern California Healthcare System. She also heads the Wound Healing Clinic there and provides care to patients with chronic ulcers and carrying out clinical trials to determine the efficiency of new drugs and devices to improve healing. She will be presenting Improving Healing with Embedded Preconditioned MSCs in a Commercial Matrix. Dr. Iseroff, if you want to take it away, it's all yours.
Are you able to see my slides?
Not yet.
Okay, that's a problem. Hang on. Don't know how to end this. Pardon me. I can see my slides, but that doesn't help you.
That's okay. I'll keep going while you're looking.
Okay, here we go. Let's try it again. We tried this earlier and it worked.
We did, and you had it.
Okay, let's do
So in her
slideshow.
time at University of California, Davis, she has been a member or chair of multiple university-related committees, as well as several professional societies, such as the Society of Investigative Dermatology, American Dermatology Association, American Society for Cell Biology, and NIH Study Section. Oh, there's your presentation. All you have to do is the presentation
Okay.
view.
Yes, we'll do.
Perfect.
Is that working now?
It is. It's all yours.
Okay, thank you. Thank you so much, Aliza. So yes, I'm a clinician investigator, so I both see patients with chronic wounds. I'm chief of dermatology at the VA, and I also run a laboratory that, among other things, is bioengineering devices to improve healing. I'm going to talk about a project that was funded by the California Institute of Regenerative Medicine over multiple years, about, I would say, 10 years worth of work. On generating a device that has embedded mesenchymal stem cells to improve healing in chronic wounds. And why stem cells, or sometimes called stromal cells? We're using the ones that are isolated from bone marrow because of ease of acquisition, easy to harvest them. There are multiple FDA trials, right? FDA approved multiple trials right now, demonstrating that safety for these cells. They can differentiate into tissues, but what we're using them for is for their immunomodulatory capabilities. They can migrate to sites of injury, and they stimulate proliferation of all the cells that are in the wounds, and can activate angiogenesis and can generate antimicrobial peptides. All of these functions, of course, would be helpful for healing a wound. So what we are using here, let me make sure that I didn't miss a slide. So we're using mesenchymal stem cells that have been preconditioned, and we precondition them with two techniques. One is to have them incubated in low oxygen, 1% oxygen, hypoxia. And does my pointer work? Do you see my pointer? I don't
Yes.
know. Oh, great. So then you can see that in that when the cells are incubated in 1% hypoxia, you get an increased number of cells in the tissue after they're injected into this mouse model, where the cells are fluorescent, and you can track how many cells are there, and you can see that as well. And then on panel B, you can see that when the cells are embedded on a matrix and then implanted into a nude mouse model, which we have here, and then we take the tissue out and harvest it after a number of days, you can see that, and we do imaging, you can see that when hypoxic mesenchymal stem cells are included, we get an increase in the angiogenesis. So that's the rationale for hypoxic preconditioning. And the cells are embedded on a matrix. We use this extracellular matrix that's commercially available. Those of you who are clinicians are probably very familiar with this matrix. It's a combination of collagen and glycosaminoglycans. It's been on the market for many, many years, has a very a high safety profile. And for us, the reason we chose this is because of the FDA approval and the long safety history. We thought it would improve our ability to commercialize the combination product using a matrix that's already been approved and been on the market for a very long time. The other part of our preconditioning protocol is to treat the cells with timolol. And timolol is a beta-adrenergic antagonist, a beta-adrenergic receptor antagonist. And we showed many years ago, almost a decade ago, that treating chronic wounds with topical timolol improves their healing. And subsequently, many other groups have done this as well. And there are at least 20 or 30 publications out in different countries showing that timolol improves healing in chronic wounds. And what we are just actually, we've just enrolled our last patient in a clinical trial for beta-adrenergic. So we have a randomized, double-blinded, controlled parallel group study to test beta-adrenergic antagonist timolol versus saline in the healing of chronic diabetic ulcers. So there's a long history of timolol and its how it can improve chronic wound healing. So both of these together are used to precondition our mesenchymal stem cells. And here's what we do. The scaffold, as I said, is Integra. Mesenchymal stem cells are plated onto the scaffold. Then they are preconditioned for 48 hours in 1% hypoxia and in 1 micromolar of timolol. Then the device is then implanted into the wound bed, and subsequently we continue to apply timolol because it has a short half-life. We continue to apply timolol to the wound bed for as long as our experimental protocol is ongoing, and in humans this would be for as long as the wound is open. Here you'll see our mirroring our mouse model. Many of you who do mouse wound healing will be familiar with these orange silicone splints. The splints are placed around the wound to keep the wound from contracting, because in mouse skin, healing occurs primarily by contraction, which is very different than human skin. So we want to limit the contraction to be able to have a model that more faithfully represents human wound healing. And you can see this is a diabetic mouse with a DBDB mouse, day 0. Day 7, you can see some of the wound has healed already. And when we quantitate this, actually not by looking at the image of the wound, because the image of the wound can sometimes be obscured by eschar or crust. And so to get a true reading of the percent healing, we do histology through the entire wound. And here you can see the yellow line is the original wound edge. There's the subcutaneous fat that demarcates that. And then you can see where, with this arrow, where wound reepithelialization has occurred, and we quantitate that histomorphometrically. And here I'm just summarizing our parameters and how we've optimized it. We've optimized for the number of cells that we need to put into the patch. And you can see that we've come to an optimization of 2.5 times 10 to the 5 per centimeter squared. If you add more cells than that, you don't really get an improvement. So we stick with this. We've optimized the timolol dose. 2.9 millimolar is the dose that is used. Topical timolol is used as a drug for glaucoma. There are drops, timolol drops, that are used in glaucoma. And the concentration of those drops is 2.9 millimolar. So we use that as one of our testing concentrations. But we found that when we go much lower, we get even an improved result. So we use now 1 micromolar. And then in this mouse model, we're able to demonstrate a significant and statistically significant increase in wound healing using the parameter of wound reepithelialization if we use the preconditioned mesenchymal stem cells on the matrix with timolol relative to just the matrix alone. Additionally, when we use this device and we do flow cytometry of the wound bed, we're able to demonstrate that in the mice that have been treated with the mesenchymal stem cells, that have been treated with preconditioned with timolol, hypoxia, and on a scaffold, when we compare the number of inflammatory macrophages, which here we're going to call M1s, to the pro-reparative macrophages, which here we're going to name M2s, you can see that in Integra alone, with a matrix alone, the M1s predominate. And this is on day 4 of post-wounding. But when we add, when we use the mesenchymal stem cells that have been pre-treated with our regimen, M1s no longer predominate, M2s predominate. And classically in the literature, people look at the ratio of M2s to M1s, and we've increased that ratio significantly by using the preconditioned patch. We've also looked at changes in angiogenesis in the wound post-treatment, and here you can see some immunohistochemistry. The red in panel B, or actually in both panels, red is for CD31, which is a marker of an endothelial cell. Blue is a cell nucleus, and green are red blood cells. and this has been imaged and quantitated, and you can see that with the matrix that's been treated with pre-treated with hypoxia and timolol, we get a significant increase in angiogenesis, significantly increased even over MSCs alone. So that's a pretty significant finding. And then finally, I think this is my last research-based slide. The FDA would like us, or like all of us who do bioengineering, to test our devices in a more relevant model. And the relevant model that's recommended is porcine skin, because pig skin is very similar anatomically and biochemically, biologically to human skin, and the healing mechanism is similar in pigs as to humans. And so we've created a pig wound model, an excisional wound model on pigs, and we tested our device. And here you can see that our device increases healing in this model as well. Now, it's statistically significant, but as you can see, it doesn't wow you from across the room. And I believe that that's because these are normal pigs that are actually quite young. These are not diabetic or otherwise wound healing compromised animals. So if we can get a significant increase in a normal young animal, we anticipate that in a wound healing impaired animal, we would get an even better increase. It's just very hard to get pigs who have been diabetic for a very long time, which is what you would need to get some of the matrix and all the concerns that you get with long-standing diabetes and impaired healing. It's hard to get a 5-year diabetic pig, and it costs a lot of money to create that on your own. So we're working on that, but yeah, we do not yet have that data. Oh, and there, one more, I'm sorry. And so this shows you that we've also here, the CD31 cells are immunostained in a magenta color, and the nuclei are stained in green. And you can see that in the treatment at the wound edges next to the matrix, that's this is the preconditioned matrix, the MSC matrix with timolol, we get an increase in angiogenesis as well. So both in the porcine and in the murine model, this improves many aspects of healing. So in conclusion here, we've shown that preconditioning bone marrow derived human MSCs, this is what we've used with hypoxia and timolol, increases their pro-reparative activities in vivo. The pro-reparative activities is epithelialization, angiogenesis, and change in the inflammatory milieu. We've shown that both in a murine and a porcine model. In addition to epithelialization, we showed that it alters the M1-M2 ratio and increases angiogenesis. And we have met with the FDA for a pre-IND meeting and have a pathway forward for IND enabling studies to be able to translate this to a clinical trial. What we need is the funding to go forward with this, and that's what we're working on. So I just want to acknowledge the group in my laboratory. Shinya Yang is our project scientist who leads this. Dr. Jan Nolta and Dr. Fernando Fierro are the head. Well, Jan is the head of the stem cell facility at UC Davis, and of course the large animal surgeons help us to put these models together. And we've had a grant, in-kind grant from Integra to provide us with the materials. And this work is funded with about 10 years of funding from California Institute of Regenerative Medicine Stem Cell Agency. That's it for me. Thank you for listening. And later on, I'll be happy to answer any questions.
Thank you. That was a great presentation. Thank you so much, Dr. Issaroff. I love that Integra product, and I like how you're combining it and mixing it. I do that clinically as well, mix things. I like that there's going to be a standard coming out. I think I'm the next speaker on our agenda. Let me see if I can share my screen as we're going. Bear with me. For those of you who didn't hear the introduction earlier, I'm from the Salem VA Medical Center. Let's see. Can you guys see?
Yep. Yes.
Perfect. Say it says I am sharing. Although, what am I sharing?
There it is, the foot picture.
Okay, just wanted to make sure it was loading.
Yes.
All right. All right. So why do research on diabetics and wounds? Diabetes-related lower extremity complications are among the top 10 global disease burdens. Diabetic limb complications cost more to treat than the top 5 cancers. Studies have shown that having a diabetic foot ulcer is an independent risk factor for mortality, 50% within 5 years having an amputation. So just having a foot ulcer or Charcot puts you around 35% in 5 years, which is similar to all the cancers when lumped together and more than breast cancer when singled out. So then when you add like critical limb ischemia or a major amputation, the mortality rate is greater than 50% in 5 years. The incident rate of a diabetic foot ulcer after it has closes with time is 40% at 1 year, 65 at 5 years, 95% at 10 years. So just getting a wound to close is not the only challenge. It requires close monitoring, offloading, and preventative care. So even with the best of intentions from both providers and the patient, the chances are that with time, this ulcer is going to come back. So the number of diabetic patients continues to rise and is expected to be more than 30% of the US population by 2050. 33% of diabetic patients go on to ulcers, half of them becoming infected. These wounds last on average anywhere from 12 to 13 months, but this varies widely. Many of them will be or remain open and never heal, and up to 22% of diabetic foot ulcers go on to amputation. Oh, why aren't you advancing? My slides aren't syncing for some reason. I have a slide for disclosures. I have been funded by many topical oxygen products, and the disclaimers are that I work for the VA. So I want to share how my various oxygen studies changed my perception of how and where we can deliver wound care, wound healing outcomes, and increase patient engagement, and can deliver operational efficiencies, kind of combining everything into one here. So what is the future of healthcare? The location of healthcare is changing. 90% of seniors want to stay in their own homes as they age. The elderly population will be over 73.1 million this year. So point of care testing and advanced technology will allow us to engage patients in their home settings. It will provide information quickly outside of a lab. Point of care testing has been shown to reduce hospital stays, improve adherence to treatment, and reduce complications. Technology will be fundamental in wound care. There will be smart dressings that deliver the needed components, medications, and cells to a wound bed. Wound grafts products will be printable and customizable and autologous. Advanced cameras will be able to capture the 3D dimensions of wounds. Cellular printers can then lay out the substrate of the cells, and we will have harvesting procedures that will avoid animal and human contaminants. So the VA's health administration actually has a strategic initiative around improving healthcare through technology and by engaging veterans and healthcare teams outside of our traditional healthcare visits. So most oxygen therapies, apart from a hyperbaric therapy, can be conducted in a patient's own home and used in conjunction with many other wound care products. So why oxygen? Oxygen plays a significant role during every phase of wound healing, from angiogenesis and revascularization to cell membrane and energy production. It promotes growth factor signaling transduction, collagen synthesis, cell proliferation, reepithelialization, and it is even involved in antibacterial activities. The disease progression in chronic wounds disrupts the availability of adequate oxygen supply to the wound tissue. Wounds can receive oxygen from the bloodstream via perfusion and from oxygen uptake through the skin, but yet both wound perfusion and blood oxygen levels are frequently insufficient in patients with chronic wounds due to poor circulation, vascular disruption, and vasoconstriction, thereby reducing the wound's capacity to overall heal. So in healthy tissue, you find that the partial pressure of oxygen is about 100, and then in a wound around the edges, it's actually 60. And wounds typically heal kind of from the edges going forward towards the center. And the center of a wound, the oxygen level is well below 10 millimeters of mercury. So a wound bed, in theory, is hypoxic. So I'm going to go over some of the basic science studies. So this animal study looked at damaged epidermis tissue. One side was covered with an occlusive dressing and the other one with an oxygen permeable dressing. The side that allowed oxygen in from the air healed and showed healthy partial oxygen levels, whereas the occlusive side decreased and did not heal. Another animal study looked at full thickness wounds. Topical oxygen was applied at low pressure. As you can see, within 4 minutes, oxygen had diffused into the wound tissue and elevated the local partial oxygen pressure from 5 to over 40, proving that even with low pressure, oxygen can diffuse deep into wound tissue and elevate local partial pressures. There was a 10-fold increase in partial oxygen pressure after 4 minutes. Topical wound oxygen therapy use and resultant increase in wound tissue oxygen levels has also been demonstrated in both animal and human studies and significantly increases growth factors related to angiogenesis, specifically vascular endothelial growth factor, basic fibroblast growth factor, and platelet-derived growth factor. There is a lower reoccurrence rate in topical oxygen treatment groups. It promotes stronger tissue by establishing sound cross-linked collagen fibers with a greater tensile strength, well-demarcated dermal epidermal junction, developed PEG layers, and organized basal cell layers. This animal study evaluated the effects of topical oxygen therapy under ischemic conditions, and the wound healing time was shorter in the topical oxygen therapy group than the control. So let's take a quick look at the available oxygen devices and technology that we have to correct the oxygen balance. This image shows multiple modalities in oxygen delivery. There are multiple or single person hyperbaric chambers. Both are topical and systemic and cannot be done at home. There's many contraindications, risk to the patients, and the patient has to go to a facility. And then the others on this page are topical oxygen modalities, and they include various air delivery devices at different pressures. Then there's the hemoglobin type sprays. There's continuous release dressings, which are based on moisture, and hydrogel dressings that release oxygen through chemical reactions. So now that we know why we want to treat diabetic foot ulcers before they have an infection that leads to an amputation, how oxygen plays a role in the healing process, and the basic science behind topical application of oxygen, we can actually look at the human application of such and see some results. So I'm going to present a mix of my oxygen studies as we go forward. The first study I was involved in, we called the TWO2 study for short. It was a multinational, multi-centered, randomized, double-blinded, placebo-controlled trial. We wanted to evaluate the efficiency of cyclic topical wound oxygen therapy in the treatment of chronic diabetic foot ulcers. The primary endpoint was closure at the 12-week mark. This is a Kaplan-Meier curve, which shows the separation between the study groups throughout the active 12-week trial. The active arm was shown to be superior to the sham arm at 41.7% completely healed at the 12-week mark versus 13.5% in the sham with a p-value of 0.007. Wound area reduction for the topical oxygen therapy group showed a mean reduction in ulcer size of 64%. So larger open areas, wound areas, incidentally, greater than 4 centimeters had a reduction in ulcer area from baseline. But in the sham, they actually had an increase in size. So larger wounds did really well. So this trial demonstrated that at both 12 weeks and 12 months, cyclic pressurized oxygen therapy was actually superior in healing chronic diabetic foot ulcers compared to just optimal care. There was a 4.5-fold increased likelihood of healing at 12 weeks in patients who were in the active arm. The durability of wounds, as measured as the reoccurrence rate at 12 months, was 6-fold better than that in the sham group. The purpose of the next study was real-world evidence, because clinical trials are not randomized controlled trials are not the same as real world. So this one was a cohort study between 2 VA facilities to evaluate whether utilization of cyclic pressurized topical oxygen wound therapy had any impact on the incidence of diabetic foot ulcers related to hospitalizations and amputations over a 12-month period. So we did some propensity score matching, and we had a matched cohort of diabetic foot ulcer patients with topical oxygen versus without oxygen. 82% fewer patients were hospitalized, and 73% fewer patients had amputations compared to those who did not receive oxygen therapy. That p-value was 0.0007. So the odds of hospitalization and amputations when not treated with an oxygen group showed a corresponding 8.9 times greater likelihood of hospitalizations in the non-oxygen therapy arm compared to the oxygen, and a 4.9 times greater likelihood of amputation in the non-oxygen arm compared to the oxygen therapy arm. So this real-world evidence study demonstrated that cyclic pressurized topical wound oxygen therapy positively impacted patients' quality of life, resulting in significantly reduced rates of amputations and hospitalizations in diabetic foot patients. The next study was a pilot study over 12 weeks, and it was with a continuous topical oxygen therapy system. And this time I coupled it with a point of care, wound care software, and telehealth. So the frequency of dressing changes were dictated by the wound condition. Patients were monitored and wound measurements were captured using a 2D digital wound measurement tool through an advanced wound therapy platform. And all visits, for the most part, were non-face-to-face, and those were conducted through the platform. There's a couple in the beginning that were face-to-face and as needed based on the findings. So patients were enrolled in the study who had diabetes and chronic wounds that had no change in wound size for 4 weeks. And on average, their wounds had been there for about 4 months. This is a quick look at the schedule of events. Oops, sorry, kind of passed through that quickly. The average wound size reduction was 96% in 12 weeks. The traditional patient encounters were estimated and then compared to the actual encounter interactions in the study. So clinical time and clinic visits were decreased from expected. Using the advanced wound care digital platform with telehealth, remote assessments were made possible without compromising outcomes. Normally, managing 8 patients over a 12-week period requires 104 face-to-face interactions, which equates to approximately 70 hours of clinical time. However, during this study, clinical interactions were increased by 54% because of the software and technology, but the clinical time was actually reduced by 25%. So in conclusion, managing diabetic with chronic wounds is going to be challenging, and we have an abundance of them. Having therapies that will make a difference is imperative, right? Home-based therapy options coupled with remote telehealth promotes aging in place and even expands patients' access to specialist services in rural areas. Point of care wound care technology will allow for rapid and timely analysis by the provider to dictate the clinical outcomes. Changing how we interact with our patients by leveraging both a digital platform and a home-based oxygen therapy will accomplish superior healing outcomes, greater flexibility, and how individuals are managed. And it enhanced patient autonomy and engagement and compliance. So going forward, oxygen should really be included as an adjunctive therapy to any wound care advances that we might want to develop. And that should be my presentation. Let me come back. I think I stopped sharing. Bring it back up. All right. I think I stopped sharing, right? Wow, there are so many more interesting topics to explore today. Next is Dr. Cordes. He's an assistant professor of mechanical engineering. Please welcome him. He's going to give a brief little introduction on himself, and he's going to be presenting on patient-specific 3D printing of electromechanical systems for biointerfaces. You ready?
I forgot to unmute myself, but I was ready other
That's
than
okay.
that.
All right, go for it.
Okay. Yeah, so I'll give a quick introduction to myself. So I did my PhD working on electronic skin, which included projects related to stretchable materials, sensors, and signal collection elements. I subsequently did my postdoc working with printed soft actuators, mainly for applications in wearable haptic devices. Now that I'm an assistant professor at Purdue, we've applied this knowledge of sensors and actuators to work on printed electronics with custom designs for patient-specific wearable devices. So you can see that my work is kind of very tangential to the topic of wound healing. So I'm kind of just happy that I'm allowed to be here. But I think my perspective is to give a summary of some of the very low TRL emerging technologies that may have the potential to be integrated into wound healing technologies in the future. So I'm sure this community is already very aware of how important 3D printing has become in the medical industry. A few examples include, the use of hospitals for making things like 3D printed replicas of patient anatomies that can be used for surgical training. There are several startup companies like Cortex Casts, which are using 3D printing to make custom designs of orthopedic casts. And many groups and companies are working on things like bioprinted organs. So I'll give an overview of some of the trends in the field of printed bioelectronics, which includes the development of new materials, new printing approaches, and some new systems designs that are enabled by those materials and printing processes. So in this presentation, I'll focus more on some of the specific technologies that we're working on in our lab, but these technologies highlight kind of more general trends that many other groups are also working on. So the printing applications that I highlighted a few slides previously focused on structural or biological functions. However, for applications in sensing or stimulation, electrical functionality is often needed. So here we show the capability of using multi-material 3D printing to deposit sensing structures with multiple functionalities, including a stretchable substrate, the conductive ink shown in silver, and the sensing ink shown in black. We can also pick and place surface mount chips that act as kind of the signal collection functionality. And this is a pretty common approach that we use things like chips to do high-level functions, and then we need the stretchable electronics printed around it in order to interface with the biological systems. So now that there's some common commercial printers from companies like CellInk, which can accommodate 6 different materials, this type of multifunctional printing is actually really taking off and accelerating very quickly. So one example of a recent project emphasizes these materials design conditions. We developed a unique ink composite that accomplishes a unique and specific strain sensing functionality. We used a fluorinated elastomer for the substrate due to its high stability and compatibility with the sensor ink. The substrate included 2 mechanical components that accomplish strain isolation around the rigid tip. So this particular device was used for biomimetic sensing capabilities, but the general message that I'm trying to get across is that we can use multi-material 3D printing to rapidly prototype systems with complex electronic functionality by holistically designing a set of compatible inks. And so this particular system has pick-and-place components as well as 2 mechanical inks and 3 different electrical inks. In addition to multi-material printing with multiple individually controlled nozzles, we can also use multi-material printing within a single nozzle. So this allows us to make more complex structures like coaxial fibers that can be used for sensing or actuating. This process of multi-material printing out of a single nozzle has a few advantages that include precise registration between the materials and the ability to print feature sizes smaller than the nozzle size. For example, in this print, even though the minimum feature size of the nozzle was about 200 microns, the thickness of the outer layer could be as small as 10 microns. So in this particular example, we were using these printed coaxial devices as artificial muscles, which were activated by applying a voltage between the inner and outer electrodes. 3D printing allows us to make these actuators in any geometry you can think of, including this kind of a helicoid structure. Now, this particular helicoid structure is not really useful for anything, but we can also make things like these lattice-structured actuators that we're looking at using to study mechanobiology in 3 dimensions. Since it only takes a few minutes to print these actuators, we could certainly envision making them in patient-specific geometries. So there's a major increase in the popularity of soft robotics recently that can be leveraged for a diverse range of actuators, including magnetic and ionic. We focus on ionic actuators shown here that operate below 1 volt and are well established to be biocompatible. In our particular work, we developed simplified controlled interfaces that allow independent and simultaneous control of many actuators. Lastly, when it comes to materials, we've been working with a set of very unique polymers from a collaborator at the University of Connecticut. These polymers have strong antioxidant properties. It's exceptionally hydrophobic, which allows us to control the degradation rate when it's in contact with biofluids. And we can also control the mechanical properties to have a range of glass transition temperature and modulus that range over a huge range of properties that's typically much larger than most other polymers. And in particular, we can make these polymers into very soft or very stiff structures. We use these stiff and soft components to design printable medical devices, such as ECG electrodes, in which the stiff component is used for the electrode material, and the soft component is used as a non-irritating and water-repellent adhesive. You can see here where we first printed a ring of the adhesive around the outside, and then we're now printing the electrode in between. So for ECG electrodes in particular, they don't actually need to be 3D printed. We can make these much easier using something like screen printing. But for more sophisticated devices where 3D geometries or patient-specific geometries are useful, this capability could be more valuable. So the fact that these materials are both hydrophobic and highly biocompatible allows us to make electrodes that can be worn on the skin for a long time, including wearing them underwater. So in another example, we use the same set of materials to create things like wearable heaters. In this case, the 3D printing process enables custom geometries. So you can see here we're just printing this, circular type shaped device. Again, it doesn't really need to be circular, but this is just to show that we can make it in any geometry that you might want. The composite nature of this conductor allows the Joule heating process to be self-limiting at a certain temperature, which can prevent thermal runaway and damage of the tissue. So that was kind of a summary of, a high-level summary of some of the key projects that we're working on right now in the lab. But I wanted to also give some examples from other labs about people who are working on some really impressive things. For example, my postdoc advisor at Harvard recently published this work where they used this multi-nozzle to do printing onto uneven surfaces. And one of the potential applications that they highlighted was in wound healing devices. Now, in this case, they just published the printer with no electronic functionality. But previous work at the University of Wisconsin by the lab of Michael McAlpine looks at the possibility of using things like 3D printing to print directly onto biological structures. Now, these are multi-material electronic devices. So a second example showing more sophisticated integration of biological and electronic treatments is from the lab of Tal Dabir in Israel. They bioprinted cell-laden tissue with electrodes embedded in the tissue. These electrodes were used to both record electrical signals from the tissue as well as provide electrical stimuli. This shows a promising direction in which technological intervention could allow closed-loop therapeutic interventions that include both sensing and response. So as a summary, we use 3D printing to make custom geometries. The field of stretchable electronics and electronic skin provides systems and device capabilities to accomplish things like sensing of electrical signals, mechanical deformation, and temperature. Device expertise and materials expertise also exist for stimulation using thermal, electrical, and mechanical stimuli. And it's well known that all of these stimulation modes can enhance the wound healing rate. For example, recent work from Harvard emphasizes the value of mechanical stimuli in enhancing the activity of fibroblasts in wounds. Lastly, most of these functionalities can be achieved using emerging polymers such as biopolymers that have better biocompatibility and antioxidant properties, as well as controllable lifetimes. So the reason I'm excited to join this meeting is to try to make connections to people with to see if some of these capabilities can be translated into future applications in wound healing. So I guess the key takeaway is just that this background, or there's the proliferation of expertise in things like electronic skin and soft robotics. And those expertise can, I think, be used for making things like closed loop wound healing devices that could potentially even be patient specific. So thanks for your attention. I guess I'll have questions later.
Dr. Cordes, that was a great overview of all the possibilities that we have to use that technology. I'm looking forward to what we come up with after this in our Q&A session. Our next speaker is Dr. Freck. Her primary goal in research and clinical care is early diagnosis and effective healthcare delivery to the systemic sclerosis patient population. She is a rheumatology fellow. She was impressed by how little we actually effectively offer these patients. So as a trainee, her primary research effort was to develop a team, so a clinic, and then this became one of the largest in the United States. It's recognized by the Scleroderma Foundation and the Scleroderma Clinical Trials Consortium. She started a similar program at the Vanderbilt University in 2021. Her specific research interest is to better understand the natural history of the vasculopathy in these patients. Dr. Freck, if you want to take it over.
Wonderful. Can you see my screen okay?
I can. You're good.
Okay, perfect. Thank you so much for having me. I am very honored to be here amongst the other speakers, and I really enjoyed the talks. I am the section chief of rheumatology at the Tennessee Valley Healthcare Systems Veterans Affairs Medical Center, and where we're really trying to focus on how to integrate clinical care in wound care. So I have, is this advancing okay? My screen?
Not yet.
Oh. There we go.
There you go.
I have no relevant financial disclosures or conflicts of interest. And as a rheumatologist, I'm particularly interested in wounds that occur in the setting of Raynaud's phenomenon. So Raynaud's phenomenon is where there's a vasospasm of the finger. And if it's prolonged or severe, there can be the presence of a digital ulceration or infarction of the digit. And so the goal of a rheumatologist is to not only recognize these promptly, but also get proper vasodilation on board as quickly as possible. So in order to improve perfusion of the fingers and prevent digital ulcers, we really want to understand how to restore blood flow, improve function through the three pathways that our vasodilators work at. So we borrow a lot from our pulmonary hypertension colleagues and use these medications to try to vasodilate and perhaps have an antiproliferative effect. Unfortunately, there are no FDA-approved drugs for Raynaud's phenomenon, and this is really because clinical trial design has been so poor with the regards of treatment of digital ulcers. And a lot of our research funded through the Veterans Affairs Medical Center is looking how you can keep vasculature healthy. So understanding the mechanosensing of the luminal layer of endothelial cells. So if we're going to talk about wounds and autoimmune disease, just even using that term is it can be a bit confusing, because these can occur both in the digits, like we just showed, due to repeat ischemic perfusion injury, but also as on the extremities as well, as elbows and lower extremities. And when we're just looking at the hands in particular, you can see that even the etiology of the wounds can be from trauma and due to fixed contracture. Here in a scleroderma patients, the fingers are fixed and these knuckles get brushed against the surface. This can also occur, of course, on those elbows. It can be calcinotic in etiology, and this is where the ischemia reperfusion injury occurs, and calcium is laid down during the vascular repair process. And then if there's just repeat Raynaud's severity, you can get digital pitting ulcers that occur that can reopen. And these are representative not so much of inflammation, but just repeat ischemic reperfusion injury with fibrosis. So we have some problems, of course, when we try to look at cohorts of digital ulcerations, because even in rheumatic disease, the variability in cohorts is reported between 8 and 50%. Now, the 50% really is the systemic sclerosis population, which are the patients that I am passionate about improving healthcare. The lack of effective treatment, however, is really limited again by our clinical trial design. So even when we just look in the literature and say, how can we best design clinical trials for these patients, the ulcer definitions are very different. There's a very good systematic literature review that says, this is the problem with trying to just use the term ulceration. We need to understand what we're talking about in order to understand how to heal them. Additionally, when we use multiple different investigators, there is poor inter-rater reliability among the clinicians taking care of these patients. And that's important because there's inconsistencies then in the therapeutic decisions being made and a challenge for data interpretation. And this probably will be shocking to this audience, but in clinical trials for this indication, photo documentation is not routinely used. And I think that's a pivotal point, because shown here in a typical systemic sclerosis clinical trial for digital ulcers, if the trial enrolled patients with a digital ulcer distal to the DIP and a diagnosis of systemic sclerosis, and this patient was placed on placebo, and this patient on an active comparator, this patient on placebo would likely heal before this patient did. And its standard trial definition has been complete healing of the ulcer rather than looking at rate of healing. So lots of problems in the way we're studying these patients. So the point of my initial VA Merit Award was we have to understand how to use vasodilators for prevention of digital ulcers. We've done our patients harm if we just wait until they have an ulcer and then we start responding to that. And so for this study, we took patients with systemic sclerosis and we performed flow-mediated dilation. So patients had an ultrasound probe placed on the brachial artery. We measure the diameter of the brachial artery and the velocity of blood flow through that artery. We then occlude the cuff, and then after we release the cuff, you can calculate a change in the percentage of the velocity and size, as well as a post-occlusive reactive hyperemia. We do this using edge detection software. What we found in our patients with systemic sclerosis compared to healthy controls that were age and sex matched was that in our scleroderma patients, the patients with digital ulcers, shown in red, digital pits shown in green, and without digital lesions shown in yellow, clearly showed that blood flow is important, response or peak hyperemia was reduced in those patients with digital ulcers, and they had a lower ability to vasodilate in response to the ischemic injury. And so you might say, well, okay, this is a snapshot in time. Again, we're trying to predict who's going to develop digital ulcers. What does the data show in this population over time? And in fact, that's what we did, shown here in yellow. We looked at change in blood flow, suggesting that for equipoise, we should not be doing digital ulcer trials with no background therapy or placebos. We absolutely should be maximizing our blood flow to these digits. But then we really need to understand how to fix shear rate change in these patients with digital ulcers. So they were unable to respond to that mechanical sensing on that luminal side of the blood vessel to vasodilate, which is an opportunity, of course, for treatment. But it also highlighted when we looked at the subset of patients that were on all these vasodilators and still couldn't heal their ulcers, that we needed to understand how to integrate wound care treatment into our treatment algorithm. And so to do this, we actually turned to an Office of Rural Health, a grant opportunity, and we said, we really want to see, this is a rare disease, so we want to see all veterans that have this complaint early. And so we worked with the different CBOCs. I did this study out of Salt Lake City. We worked with all our surrounding CBOCs to develop a telehealth program to get patients referred to us right away if they had a digital ulcer. We had several significant observations over this year-long grant. That the current the referral process for getting patients into a rheumatologist was incredibly inefficient, particularly because there's a shortage of rheumatologists in rural areas. We needed to do this well, and in a rare disease, a single rheumatologist can serve many patients with a rare disease. But it wasn't just access to a rheumatologist, it was access to a rheumatologist paired with a wound care specialist to provide the best urgent assessment as well as coordinated care for management. But most importantly, we identified that almost universally, if a patient had Raynaud's phenomenon with a scleroderma or a specific serology and abnormal capillaroscopy, so all the CBOCs had adequate dermatoscope in their office, we could project and diagnose patients early with systemic sclerosis, which had significant impact on taking good care of our veterans. And so we took this concept and we applied for a VA Teams project and said, you know, we have a lot of challenges for our as a rheumatologist treating rheumatic disease ulcerations. First is ideally we would be able to find patients through Vinci or from a database. We'd say, let's locate these patients and then bring them in and say, let's manage your hand complaints better. The main issue is most of the clinicians documenting ulcers are not doing this well. So they're not describing how deep the wound is in the dermis, if there's a break in the basement membrane, or how deep these wounds are. Additionally, we said if we don't know how many patients are out there with these ulcers and Raynaud's, we also can't power our studies to understand duration of treatment. Meaning, if we're going to treat a digital ulcer to completion of healing, in this population, we actually don't know how long that treatment trial should be. Similarly, we are seeing lots of different variable drugs being used. There's no FDA targeted approach, but in the VA system, we could better understand the use of medications and in a tier-like structure. And then if you have a single provider really doing this care, you can account for the heterogeneity of the clinical features, understanding the nuances of rheumatic disease. Is it vasculopathy or vasculitis? Does immunosuppression need to be added to vasodilation? And then lastly, we really wanted to understand in the VA system, how can we look at our veterans and find these wins or successes? So when we're doing a good job, how do we communicate that to other VAs to be able to do this well? But more importantly, how do we tie this into research? Because the mechanistic studies are really critical for us understanding pathogenesis. And so we said, let's do this. Let's try to figure out how to have a research program that's based on already existing algorithms. So and this is my call to, or my plea to many people out there on the call. Hopefully this will resonate with some of you and be of interest of collaboration. So with Raynaud's management, that the key is establishing early diagnosis, optimizing the wound care when it occurs in that setting of Raynaud's, and then of interest, if all else failed, you consider sending the patients for digital sympathectomy. But what we can also do is a chemical sympathectomy with Botox injections. There's a lot of potential here to do a better job with fingers within established guidelines through the VA setting. So the first kind of idea here was applied as a VA Teams project. I was not selected, but it was a good process, and that we worked with many experts in the VA system to say, how can we really use telehealth or image upload to to initiate a Raynaud's-related digital ulcer referral process. Because if we're able to see that picture, then we can start right away and get the appropriate diagnostics to then coordinate the subspecialty care. And if you have a good pipeline in of patients with a complication and you're taking good care of your patients, you then can start looking at novel treatments and more advanced diagnostics. So this is sort of the first point of the project. Now, the rationale behind this is how we currently do this in a rare disease. 95% of the time works okay. It's not good for our veterans, but it works okay. And let me explain what I mean by that. 95% of the time, if you have Raynaud's with this ulceration, you're going to present to your primary care provider. Primary care provider is going to say, hey, maybe you need to see the surgeon. That finger looks pretty bad. Surgeon says, nope, this is more of a superficial wound. I don't need to perform surgery. Sends the patient back to primary care. Who then might say, well, maybe it's infected. I'm going to send you to infectious disease because it's not responding to the antibiotics I'm prescribing. And the infectious disease might say, nope, this is a vascular ulcer. You need vasodilators. And because they're Raynaud's, maybe you should send that patient to rheumatology. There's that wastes the patient's time. There's delays with costs and getting that wound treated, because as there's delays, the wound's getting worse. And more importantly, we're delaying the diagnosis of connective tissue. We said, at 5% of the time, that patient actually loses that finger. And if that is you or your patient, that's a big deal. And that 5% is really, really important. And so we said, through this proposal, what can we do at the VA with access? And we focus on physician productivity. All my clinicians out there will shake their head. Bookability is key. How can we get our physicians seeing the right patients more urgently and have patient outcomes assessed? And so we said just a simple picture can help. And we did some preliminary analysis that said hangnail, totally fine to go to a primary care doctor. But if there's some other complications, we really want to get those patients into the right provider. And that's very simple if you're having just the image as part of the referral process. And in particular, if you just use that dermatoscope in the CBOC and your clinician can see it, you can make that diagnosis of a connective tissue disease. And in the case of scleroderma, you can really save fingers. And that really brought to the next point, or aim two, was we can't do this alone as rheumatologists. So we can make the diagnosis, we can see these wounds, but what we really want to do is get the right wound dressings to our patients. And that's actually why I started attending these meetings and these symposiums, which are incredibly valuable, is to know what is out there for us to help our patients, particularly in these areas where dressings don't adhere very well because it's fingers. They oftentimes get super infected because patients are wiping themselves, and it's hard to optimize hydration because patients are cooking and using their hands. And then as rheumatologists, we actually weren't sure how often should we be doing remote wound care dressings, and how often do we actually need to bring the patient into the clinical wound care center so that we're monitoring these. So as a rheumatologist, I can prescribe vasodilators, I can prescribe immunosuppression, but the wound dressing part I was really struggling with. And so what we said is okay, we were seeing these wounds in clinic, we could do our time algorithm, but we really want to know what's the best dressing. I got a small foundation grant looking at amniotic dressings, and these were really life-changing for our patients. They helped with pain relief, and they helped healing these skin wounds. And we said, okay, dressings in addition to vasodilators are key. And we want to understand how these are promoting angiogenesis, suppressing inflammation, and inhibiting oxidative stress, all the side data we were getting from those flow-mediated dilation studies. The reasons these make sense are they're immunoprivileged, they have the growth factors we need in anti-inflammatories. We're particularly interested in hyaluronic acid as a biomarker, and we can really examine these wound dressings after they're removed for what's occurring on the wound level. That brings us to the very last sort of concept here, was wound healing quantification. And so we long realized that trying to get patients to measure their wounds remotely is challenging. Doing it in the clinic doesn't do justice. If we're bringing patients into clinic, ultrasound is really helpful. We've been in the process of building a ultrasound program here at the Tennessee Valley Healthcare System. We had a small grant from the Scleroderma Research Foundation looking at just giving patients tissue analytics apps, which allows them to take a look at the wound, upload it to the cloud, and the provider can take a look. This has been fraught with complications on how you protect patient healthcare data and get that into the medical record. So while helpful for patients and doctors, it's difficult for research purposes. And then lastly, I wanted to give a shout out to the DoD because we did a work on developing a patient-reported outcome. This is the first one ever for Raynaud's phenomenon in a short-form measure that's founded in the patient experience. So we did this over many years, having patients provide feedback and get a questionnaire that we can finally use to say, is this drug working or not? And again, as I started, there's no FDA-approved drug for this because we didn't have good outcome measures to study it. So in conclusion, I'm hoping I'm convincing the audience that we really have a critical need to address autoimmune wounds in the VA. And I think we have a lot of good opportunities here to collaborate through the telehealth services, through clinical effectiveness measurements, particularly looking at dressings in conjunction to the standard care for rheumatologic wounds. And then ideally, this thought process of being able to apply artificial intelligence to vast data sets has great potential, but we've got to get the right data in the VA system. So really working as a clinical side to have these wounds really well characterized so that we can understand things as simple as how long it takes for a wound to heal and what drugs are effective. If I didn't convince you to do research for me, I hope I did at least educate everyone on that all Raynaud's patients should be educated on the possibility of ulcers, that if they're rheumatic related, that we really can prevent complications if we're using vasodilators, and the VA Merit Award has really shown this robustly. And that once there is a wound ulceration or a digital ulceration, education and treatment are imperative. And I personally have really worked hard to try to be the scleroderma person in the VA system. I'm happy to take phone calls, emails, anything on a veteran with a diagnosis of scleroderma. I'm very passionate about this patient population. I hope I've introduced the concept of amniotic wound, amniotic membrane dressings for systemic sclerosis. And then lastly, highlight that there's lots of different quantification measurements that we're trying to develop. And with that, I will thank you all for your attention. I hope I stayed within my time range. I practiced it a couple of times. I probably talked too fast, but I do appreciate your time and attention.
Thank you so much. That was great insight into unmet needs and technology. We definitely have Raynaud's in the feet. It's an issue here in my facility, not a big one, so not enough patients that would help you out, but definitely it's a need. We're a little bit behind. Our last speaker of the day is Dr. Snyder. She's going to go over burn and regenerative medicine research funding. Quick little overview to keep us on time. She's a board certified nurse with 20 years experience in nursing. She has a focus on critical care, emergency, and flight nursing. She was in the Army Reserve as a LPN, and then she became sergeant. And since that time, she has worked for the Army Corps as a critical care nurse. And she's done the Army Reserve thing for, it looks like, many years. She's been sent all over the place.
That's good
thank you
enough.
for
We
your
can just
thank you
move
for your
on.
service. I just no, thank you, appreciate it. And please,
And
by all
I can
means,
just
give
talk
us a
about
little
what I'm
insight.
currently doing.
Sounds great.
Yeah, thank you so much. I appreciate that, Aliza.
Yeah.
So I currently manage, along with Dr. Robin Walker, we manage the Military Burn Research Program. And actually, let me bring my slides up here and I will get working on this. Let's see, that's not the one I want, but let's see. Okay, can you see that?
Yes.
Okay, perfect. So that's me and Dr. Robin Walker. Her and I work, we're a two-man team. We manage the Military Burn Research Program at the Congressionally Directed Medical Research Programs. My hope here today is to provide you with an overview of our program, who we are, what we do, and the various programs that might be relevant to the research that all of you are conducting. I thought the presentations were wonderful, and it just kept I kept thinking throughout, okay, which program should this person apply to? Which program should that person apply to? I'm sorry to say that we don't have a specific research program that focuses specifically on wounds or biofabrication, but I think that you'll find some programs that are relevant to your research areas. So just briefly, I'll just kind of go over who we are at CDMRP, and on the next slide, you'll see a little bit more about who we are. But as any organization, we have a vision and a mission, and our overall vision is to transform healthcare. We'll do that through innovative and impactful research. We were founded as an organization in 1992. A group of breast cancer advocates and breast cancer survivors went on the Hill and said, we need something other than NIH funding that would be product driven and help us get the treatments that we need for breast cancer. So various service components within the DoD were tapped to hold on to this funding, and Army actually was the only organization that said, we will do this. We'll take on this funding and we'll execute this funding and get you something promising. So since that time, we have grown to more than just the breast cancer research program. So you can see here that we are up to $1.52 billion. That was for FY23. But we now have somewhere around 35 different programs. I highlighted the programs here on this screen that I thought would be relevant for all of you. We're going to talk about applying for funding opportunities or getting notifications on our website for some of these programs. Robin may have to drop off, so I might be presenting that, but one of us will give that information to you. The most important one I want to point out here is the peer-reviewed medical research program. So that program is our largest program. In FY23, it was a $370 million program. Now understand there are 50 topics-ish. They change each year. Congress actually puts in the topics for us. So underneath the peer review medical, if there isn't a program specific to a particular disease or condition or injury, it basically lobbying organizations or advocacy groups go to the Hill and say, we want funding for this disease or that condition, and they'll get thrown in under peer review medical. I hate to say thrown in, that's probably not appropriate, but they will be put, if there's not a program specifically for that, they'll be put in under peer review medical. So last year there was a pressure ulcer topic. I think that topic has been in PRMRP for several years now. We don't yet have the official language for the FY24 National Defense Authorization Act, but we hope to see that soon, and we'll be able to get those program announcements on the street and you guys can go and apply. The other program I want to point out is Joint Warfighter Medical. So this program this past year was a $25 million program. Any investigator who receives federal funding can apply to the Joint Warfighter Medical Research Program. So you'll want to stay tuned to those opportunities that come out. The JWMRP is a product-focused program, so they're not looking at basic scientific research. They are more driven by requirements and product development. Now, as I mentioned, I'm the program manager for the Military Burn Research Program. You can see we're a rather small program compared to some of the other programs on this list. We are much more focused on the early point of injury care of burn patients. So we haven't in recent years focused on tissue regeneration or skin grafts and things of that nature, but it doesn't mean we won't focus on that in the future. Just in the last couple of years, we've been more concerned about early point of injury and close to the point of injury treatments. So under the peer review medical research program, these are a list of the 50 or so topics that were included under that program for last fiscal year. So all of the program announcements for PRMRP, actually for most of the FY23 solicitations have already gone out on the street. So I think none of them, there might be a few that are open. I think I looked at some of the open announcements and most of them are cancer programs. But anyway, you can take a look through here. I think everyone on this call is getting the slides. The relevance and impact are something that we really look at in our program announcements. So each of the programs that I mentioned to you are absolutely going to have their own individual relevance. At vision setting each year, the program managers and their programmatic panels will do a vision setting, which you can see on our program cycle here is in the upper left-hand area, where we decide what it is that we are going to focus on for that particular fiscal year. And ultimately, we end up coming out with the program announcements, and they get published to grants.gov, and investigators can apply. But this is a cycle that repeats itself each year. So we'll come back to the table with the programmatic panel, the stakeholders, and really determine what do we need to focus on in each of our programs. And I don't know if, let's see, is Robin still on, or she may not be?
I'm here.
Do you have time, Robin?
Yes, I'll go forward.
Okay. All right. Thanks. I'll turn it over to Robin to talk about the funding opportunities.
Yes, so at CDMRP, we have several funding opportunities, as Dr. Snyder mentioned, through the different programs. And again, focusing on those opportunity announcements, we want to understand the importance of looking at the goals of the program, the intent of the award mechanism, and the review criteria for that. And that's usually geared towards the program goals. Again, as Dr. Snyder said, the focus area topics, award intent, review criteria, and the deadlines, of course. We want to really push that you need to read the announcement carefully. It's very important for you to do that. Next, we'll show you about the funding opportunities that CDMRP has. Again, CDMRP, you can find the funding opportunities on the CDMRP website. There are also email blasts, and we'll show you later in a later slide how to do that. Again, those opportunities are posted in grants.gov, on the CDMRP website, eBRAP, and sam.gov, and you'll find the board agency announcements or the program announcements there as well. Again, if you go to the CDMRP website, you'll see the homepage and the tab for funding opportunities, and you'll be able to find it there. You'll also see on the homepage here, as we're displaying, where to subscribe for the email notifications as well. And you can sign up for the listserv through the CDMRP website as well as eBRAP. The application process pretty much goes where you're reviewing, again, that program announcement or that board agency announcement, as we previously showed, and where you're going to register through eBRAP or SAM and submit your pre-application. And that will be, either a pre-proposal or a letter of intent, which will be received and possibly invited for you to submit a full application. At that point in time, you'll be invited to do that. And that, again, will be through the grants.gov or eBRAP, and the verification of the application will take place in eBRAP. So some of the key points in checking your application, again, making sure that you do not include any programmatic panel members from previous fiscal years of which you are, especially those of which you are applying, the fiscal year you are applying to as well. Stay within the page limits. Make sure that your files are created in that PDF version. Again, make sure to check the deadlines. It's very important. We cannot stress enough about the deadlines and the deadline time. Grants.gov does validation, and the system-to-system submissions sometimes have some problematic issues. So you definitely want to make sure that you're hitting those, meeting those deadlines, or possibly making sure to turn in those documents prior to, just in case you need any type of buffer time to make those deadlines. Very important. Also, to submit the correct project narrative and budget as well. This is also very important. There will be verification processes that are going to happen in eBRAP, but that's a very important part in that submission. Some additional tips and resources for success. Next slide. Okay.
Sorry.
No problem. So on the CDMRP website, each program has a program page, which actually outlines the strategic plan, some program booklets, summary sheets, and some other program-specific resources. Again, there'll also be some pre-announcements and funding opportunities there as well, and some research highlights, awards, annual reports, and some other webinar series and other guides and resources there as well. Again, this information is going to help you be able to specifically hone into what programs you're interested in applying to. Again, we have funding opportunity webinar series as well with these different titles as well that you can definitely look into that may help you for your funding opportunity. Next slide. So this is an example of the program page with the summary of the program and some news and highlights. They usually typically have their vision and mission statement, give you an overview of the type of funding that they usually get, as well as some of the programmatic panel members and peer review participants of previous years. So here's some strategies for success. Again, you definitely want to make sure that you're addressing the specific goals of the program. Again, looking at their program page, looking at their program books, that really is going to help you make sure that you're aligned to the proposed work with the specific guidance in the announcement. For impact, we cannot stress enough to propose those solutions that are important to the problem. Definitely make sure that you are talking to the problem or the gaps that is actually being addressed in the announcement, and make sure that when you are articulating your work, that you're articulating the translatability of how your work can make a difference or contribute to that body of work. For innovation, again, you want to make sure your rationale is very clear. Again, you want to make sure that anything you're proposing, anything new or novel, that you are having a sound approach, that you're definitely using as that innovative piece, and making sure that it is feasible. You want to make sure that it is technically feasible with clear approaches and contingencies, making sure to include evidence of appropriate expertise, any type of consultants or collaborations as well, and making sure that your study is appropriately powered as well for the research and research outcome, and demonstrate that availability and access to any critical resources, reagents, or subject populations that that announcement is speaking to. Again, you want to do planning timelines as well, include or allow any adequate time in project planning for any types of regulatory approvals through the HARO office, or any other types of regulatory approvals that you would need, like IND, IDE enabling studies. And then for those multi-organizational efforts, you want to make sure you have a clear plan of coordination and communication. Those DoD collaborations are very important as well. If you're planning on collaborating with any of our MRDC labs or any other intra-DoD component, you want to make sure that you're understanding the rules and regulations of how those partnering with those institutions actually work, whatever are the specific regulations or rules that you have to abide by, or any documentation and things that you will need in order to work with them. For the grantmanship, you want to make sure that you are proposing work that is clear with no unburdened jargon. You definitely want to make sure that the work that you're submitting is understandable. Again, it's sound work. You want to also make sure that you're speaking to your audience. Again, you have peer and programmatic reviewers that are going to be reviewing your proposals, and you want to make sure that you communicate what you're trying to do effectively. You also want to make sure you review those application documents carefully before submission. Make sure that you are, getting whatever help you need in order to make sure that you've hit all the points that are being asked of you in the program announcement. Very, very important, as well as don't break the rules for the deadlines or requirements. We cannot stress that enough. Please be compliant. And I think that's it for me.
I do want to mention, thanks, Dr. Walker. I definitely appreciate that. Dr. Walker mentioned the BA earlier, and that was a program I did not mention earlier, and some of you may be aware of this already, but the broad agency announcement for extramural applicants And I think most VA researchers come into our program with a foundation. So it's still considered extramural, even though you're an intramural agency. I think you come in through like VA foundations or something like that. So the broad agency announcement would go in and likely be brought into the Combat Casualty Care Research Program, or JPC-6. They do have a regenerative medicine and like chronic wound healing focus area. There's a new program area that was just recently stood up, and it has something, it's similar to AFFIRM. So those of you who have been involved with AFFIRM, you can look there too. I also want to mention the BioFab USA. You probably are all familiar with BioFab USA, and maybe Kimberly, you could probably speak about it more intelligently than I can, but it is a joint, federally funded private-public partnership. So anyway, that's all for us, and I'm happy to take any questions anyone might have about CDMRP or our funding. Oops. Thanks for giving me
Dr.
this
Snyder and
forum.
Dr. Walker.
Sure.
Appreciate that. So this is our question and answer session time. So I guess if you want to start with Dr. Snyder, anyone have questions for her?
Can you see that? Can you see that, Alyssa, the hand
I
raised?
can see. Yep.
Yeah.
Almonds?
Mary Cloud.
Let's see if I can get my unmute to work here. Thank you so much. This was a really, really, really interesting session, and I really appreciate the speakers, and I can think of all kinds of exciting follow-ups for collaboration and things like that. So I really appreciate you guys putting this together. One of the questions I had is that kind of in a follow-up to the last presentation, the broad agency announcements, hopefully somebody can bring some clarity to this for me, but from our NPC, we've been told that these are considered contractual relationships and not grants. So they're in a slightly different classification, which requires a different kind of paperwork and everything on the NPC side. And I'm wondering if anybody has any insights on that and how we can set ourselves up potentially to take advantage of the broad agency announcements.
So this is Sandy Snyder. I can only speak for the DoD, the USAMRA, or the U.S. Army Medical Research Acquisition Activity Broad Agency Announcement. This is, it could result in contracts. I would say the majority of broad agency announcement proposals that come in and get funded are typically grants. Now, they could be cooperative agreements, but that's basically a grant. The contracts are usually if there's a prototype being developed, that may result in a contract, but it could be one or the other. It could be grant or contract.
So if there's a way to sort of stick to the grant area, then we don't have to do sort of the extra paperwork extension for our NPC to do contracting. Okay, great. Thank you so much.
Just don't put prototype in your, don't say you're going to deliver a prototype, okay. Because the minute you mention prototype, our contracting offices they want to make it a contract. So
perfect. Great. Thank you so much.
Sure.
Dr. Israel had her hand up. She wants to speak.
Yeah, I had a question. I wasn't familiar with the Joint Warfighter Medical Program, and I thought I was familiar with every funding program. So it surprised me that I didn't know about that one. I have 2 proposals in for the CDRMP pressure ulcer call that just went out. But can you tell all of us a little bit more about the Joint Warfare Medical Program and how one even knows what if there are any RFAs or how to access information regarding that program?
Yeah, and I would be happy to put you in touch with the program manager for the Joint Warfighter Medical Research Program. She would be able to answer definitely more specific questions about what the program is looking for. But they're just like any of the other programs that are funded at CDMRP. Congress provides the language, but with the Joint Warfighter Program, the program manager sets up the priorities based on the needs of the various military components. It's not specific to Army. It could be Navy needs or Air Force, Marine Corps. You know, it's kind of pan military, but they run the gamut though. Like we're managing now a couple of burn care projects that are looking to prevent burn wound conversion. So in the last couple of years, Joint Warfighter has funded a couple of burn relevant awards. I know that they fund like orthopedic focused awards. So it just, you know, I think the program announcements, when you read them, and you can go on our website and go look at the Joint Warfighter and look at their past program announcements, look at the one from FY23. You can get an idea of what that language will look like for the, you know, in the upcoming FY24 cycle. It doesn't change a whole lot. So I think you should get a pretty good idea of what that program is usually looking for.
Thank you.
Sure.
Go for it. Oh, nope, you're muted. Oh, there you go.
Am I? Okay, I'm unmuted. Yeah, this is Jeff Travers. First of all, what a wonderful way to spend an afternoon. This is the only time I could spend it at home, and I got out of a lot of chores. Thank you. Anyway, a couple of things. First of all, I'm interested in as a dermatologist, you know, of course I see various types of ulcers and wounds, and especially autoimmune related ulcerations. And I think it's interesting, Dr. Freck, you should probably talk to Dr. Lee about topical oxygen in many of those settings, since you're already trying to increase the blood flow. I mean, that would be a natural. And I wanted to put in a little bit of a plug for, you know, subcellular particles, microvesicle particles, exosomes. It's kind of challenging to work in that space. We have several nanosites, one of them funded by the VA. Thank you, Kimberly. And if anybody has any interest in sending me some samples, you know, just contact me, let me know. I'm happy to do some preliminary studies to see if there's something in there of interest. My only condition is, you know, you have to send them to us blinded, you know. But yeah, I mean, there's a lot of potential in terms of looking at microvesicle particles and exosomes in the settings of various types of pathologies. And I'm happy to be of assistance. Thanks.
Thank you. I'll definitely be in contact.
Wonderful. I was looking over some of our chat here too. It looks like there's a question if we are going to share our slides with the audience. Kimberly, you have an answer for that?
I mean, unless the speakers don't want to share. So, you know, please, speakers, let us know if you don't want to share, and then maybe we can, I hope, open up the SharePoint. As you can understand, sending out this large volume of slides may be difficult if you're not on a VA system or something. And again, our SharePoint only talks to VA computers, but we're happy to somehow make those connections. I mean, with the help of our logistics staff or something, we can try and do that. And I think I'll put my slides there. Folks had asked about my slides because I do have links to, you know, information on our website, which is sometimes hard to find. So again, I mean, just, and someone did ask, so I'm jumping ahead of you, Alyssa.
Oh, I was gonna jump in as soon as you stop talking.
Yeah.
About the
And
contact.
people did ask about the contact information. Again, I think after Teams, we should have what we call an attendance report, and I'm hoping that that will permit us to do the outreach. And again, we'll try and do some cleanup on the logistics side at the back end, and hopefully we'll also have the recording. So again, logistically, we'll try and make sure everybody has the information that they need. And I know people had to drop because we ran out of time, but you know, and hopefully they'll be able to catch up with anything they missed. So thanks, Jeff, for your offer. And again, hopefully we'll get everybody connected by email in this wound healing space, you know, because it's so hard across disciplines, across VAs, and across affiliated organizations. It's quite hard. So we'll try. Thank you, Alyssa. back to you.
Yep, actually, it's back to you. There was another one in the chat from Terry Williams. Does one have to have active or current VA funding to qualify for the funding in reference to your presentation?
Yeah, so we're working on removing the eligibility requirement, but obviously if you're employed by VA, right, you can access these RFAs. I mean, if you've had funding before, then you can probably access these RFAs. If you don't work inside of a VA, then you can't access this, but you can work collaboratively with somebody. So you can do that. And of course, having DoD here, you can also work together, and I'm very agnostic where you get your funding from. But again, if you think, and I think, Sandy, the pressure ultrasound space is obviously in your spinal cord portfolio, and maybe a little bit in joint warfighter. So again, this is just an opportunity for people to kind of cross-pollinate ideas. And sorry, folks had to leave because there were a lot of interest based on the comments that we heard. And sorry we ran over time, but a lot of good information and sharing. Thank you.
You're welcome. There was a question for Kath Bogie. Are you still on?
Yeah, I'm here.
They wanted to know, how do you control for bacterial infection as far as upregulated pathways associated with antimicrobial defense?
So one of the inclusion criteria for our participants is that they do not have an open, large open wounds at the time when they're enrolled in our study. In previous work, we actually looked at inflammatory biomarkers in this population and found there was no significant difference between the groups because everybody with spinal cord injury has upregulated inflammatory biomarkers. They may not be clinically reach a level of saying they're infected, but they're upregulated in almost everybody, not least because there's an increasing recognition that spinal cord injury is actually a chronic inflammatory disease. Does that kind of answer the question, or ask more?
I think it does. All right, and then it looks like we have a lot of thank yous. Sorry, I have to go. Please share contact info.
Yeah.
A whole bunch of that in there, and I don't see any other questions. I do see a hand up. Dr. Issaroff, you still have a comment, or is it still up from before?
Sorry, I forgot. I didn't know how to take it down, I think. So yeah,
Oh,
no further questions.
No further questions. Okay, I'm not seeing any hands up, and I don't see any questions in the comment section. So I think we're good. We're definitely over time. Appreciate everyone's time, energy, and effort that we put into this. It was a very great, fun meeting, and I hope lots comes out of it, right?
Thank you. And thank you, Alyssa, for moderating and managing with all our technical stuff. And we didn't touch it, wound infection, and that may be a whole separate discussion, so I don't want people to feel left out, but we just thought we'll just tackle a few topics, and I thought they fitted together really well. I think, the whole constellation of ideas working together fitted really well. And again, thanks to speakers and for folks who came from VA or clinicians who had to give up clinic to come. Thank you so much. And again, our colleagues at DoD, thank you again for spending the afternoon with us. I think the information you shared was really, really helpful. And we'll get people working around sort of a more comprehensive approach, maybe to wound healing, detection, diagnosis, and data sharing, sample sharing, and things like that. So thank you so much. All right.
All right,
Thank you.
And we'll share contact information, slides, recordings.
Yeah, let me know.
Yeah.
We'll be in touch, Kimberly. Let me know if you guys need anything from me.
Yeah, thank you so much, Sandy, for coming and hearing about what we're doing in VA. So appreciate it,
Yes.
Thank you.
I hope to join for more too.
Okay,
So.
Thank you.
Bye-bye.
Appreciate it. Thank you. Good to hear from you, Tracy. At least get your updates.
Thank you so much, Kimberly. Appreciate that. Bye.
Thank you.